think if you can share the presentation.
Yeah.
A number of times during our today's webinar, we could hear the word lockdown and COVID. So I think it is very much pertinent to talk about adaptations to be done for sickle cell care disease during this COVID times. Some adaptations, go on please. Some adaptations at the healthcare center level. I think healthcare centers now should be in total readiness regarding management of sickle cell disease patient with respect to what routine care they would be giving, how they would be managing crises, and how would be they tackling the COVID-19 positive patients. Uh, like at many district hospitals, I am sure there wouldn't be a separate COVID building and a non-COVID building. So there could be a merge of patients who are non-COVID with COVID patients, and this is where sickle cell patients could land up into trouble. So whenever they are attending to hospitals or with a suspicion, there should be priority testing by RT-PCR. We have seen complaints at various levels about patients not getting reports maybe for 2 days, 3 days. This is where this waiting time of 2-3 days could be very detrimental to the health of a sickle cell disease patient who is suspected to be COVID positive. So there should be provision for priority testing by RT-PCR. RT-PCR, more or less by many studies, has shown a sensitivity of only 70%. So when we do an RT-PCR for all suspected patients, we still may be missing 30% patients of sickle cell disease who could later on turn out to be COVID positive. So it's very important to identify imaging centers for CT scans, because now HRCT is a very reliable indicator for presence as well as severity of corona infection. So combined strategy of having RT-PCR and CT scans for these patients would be a great help to initiate early treatment of these patients. Also, there should be a policy of early blood transfusion for those patients on chronic transfusion requirement, irrespective of their COVID symptoms. Next, please. Now we talk about routine care. If possible, patients should not be made to rush to hospital, and the best option is to provide teleconsultations. Private practitioners have pitched in with that. Maybe government doctors also at the PHC, CHC level could start this, because nowadays all patients have Android phones and they are comfortable with video calls. The regular medicines should not be changed, and they may be given for longer periods, like for 3 months at a stretch at the first visit. Like if they are availing of folic acid and hydroxyurea, whenever they visit the health center, they should be given medicine for at least 3 months to reduce their frequency of visits to the health center. Proper counseling should be done for all patients regarding precautions to be taken, as well as the red flag signs. That means what happens if they have to rush. What initially should be make them very alert about rushing to the hospital with a little pain. It could be a crisis resulting in a big morbidity. For those not on hydroxyurea, I think initiation would be a good thing to do, and we have to ensure vaccination coverage with pneumococci, cent% coverage. Next, please. For crisis management, it's very important that there should be early referral to the appropriate hospital. Like if a center is not equipped enough, they should immediately rush the patient to a higher center without waiting for complications to develop. And at the tertiary center, the strategy should be of aggressive management, straight away going to a level 3 management rather than a step-by-step approach. And blood transfusion should be initiated very, very promptly. Next, please. Now, with patients who are suspected or those who are COVID positive, all standard protocols for management of COVID patients should be followed till the time reports come, because it could be a flu-like illness and it could be flu itself. So without waiting, oseltamivir should be started. All patients should be put on prophylactic anticoagulant, that is enoxaparin, at the dose of 0.5 milligram per kg twice a day, because we have seen mortality in COVID is related to clots formation in the lungs. So we want to avoid that for the patients to happen. So an immediate prophylactic anticoagulant would be a great help to them. At most important, we should maintain oxygen saturation throughout the period, maybe with a simple oxygen support, with a high flow oxygen, or with a ventilation. Next, please. Now, there have to be some adaptations to be followed by sickle cell disease patients also. They all should be taking precautions like a general population. We all know social distancing, mask, as well as a sanitization. But an extra face shield will be very useful for them. That will be hugely protective and decrease their chances of acquiring a COVID infection. If they are at workplace, especially those who are working in healthcare, the patients of sickle cell disease, they should be very, very careful. At home, if they have a digital thermometer and pulse oximeter, it will be a great help to them. And simple things like if any family member is also likely to be get infected with COVID, and now with COVID spreading to the rural areas, there is always chance that tribal district, rural areas, everywhere it will go. So simple strategies, like the person, there's one washroom in the whole house. So I think the patient who is a sickle cell disease, he should be the first user of that bathroom, so that if a family person is infected, he uses bathroom, and then the sickle cell disease patient uses the bathroom. So he tends to acquire the COVID from the family member from the washroom also. So simple strategies. And another important thing would be they should identify mode of transport and center to be visited in case of any emergency. So this is what like patients need to do. Next, please. Some adaptations are must at the community level. First and foremost, like in normal situation also, but specifically in COVID, for sickle cell disease and for thalassemia patients, the dictum should be to have more voluntary blood donations so that our blood banks are adequately stocked. And everybody should pitch in, right from the community to the NGOs to the local Rotary clubs, Lions Club. And there have been great examples like collectors in Gujarat. They have provided vehicles during lockdown for transport of blood donors from their home to the blood banks. So all these initiatives go a long way because ultimately blood will be very, very important in managing this sickle cell disease patient. Apart from blood, these patients being in the remote areas, they need a lot of logistic help also, which the community can also provide. NGO should come forward to complement the efforts of the government and shoulder more responsibility in sickle cell disease projects to help overcome or minimize disruptions in care in the COVID and as well as the post-COVID scenario. Because it's very likely, I'm not very sure Vinita can say, but there could be a possible impact on the budgets, especially on the preventive side. We could see a lag of projects being taken up or some delay in the funds being sanctioned. So this is the time where the NGOs and the community should pitch in because we don't want more children to be born since corona may last for a year, maybe more, till we get an effective vaccine. So community level adaptations of supporting the projects of the government is the need of the hour. Next, please. Oh, thank you.
Thank you very much, Dr. Khatri. There are 18 questions in queue. We have 450 delegates live still, and we have overshooted our time by 30 minutes. With the permission of Dr. Pendharkar, I would like to just take up two or three important questions. One question, because this has not been addressed, we cannot take all questions. One is to Vinita Madam. From this question is regarding regarding West Bengal for hemoglobinopathies. What we are going to do? That is one question. Number two, Dr. Sanjeev is a hematologist. He is from Jharkhand. Currently, he works in Lucknow. He is interested in working for an opportunity as a hematologist in Jharkhand. And if there is a plan for transplantation center. So, Vinita Madam.
So I couldn't understand the question, please. Can you please repeat?
So one is
I will repeat. So the question is, ma'am, ki what are we doing to do something in East Bengal and North Bengal? Are there any special plans for these disorders in Bengal?
Yeah. So we have started with hemoglobinopathies. Was initiated in 2016 itself, but this has been saturated to only 6 districts. 6 districts have been taken care, and they are now planning in this year to regain it to another 6 districts. So in this year, most probably the North Bengal and other state districts will be taken care of.
Thank you. Thank you very much. The second question was, there is some hematologist doctor available and willing to go to Jharkhand. So let me reply this question. It's very good. I think we'll bring this to the notice of the government of Jharkhand, and probably they will get in touch with him, and definitely it's a good opportunity. We thank this doctor. If he's willing to go back, it will be my personal responsibility also to talk to the Jharkhand government and see how we can pitch in the hematologist for Jharkhand. Thank you very much. So I am really extremely sorry that we have to cut down here. I really want to thank everybody, especially Vinita madam, for really taking this long a time to sit with everybody, with 500 people, and discussing the issues related to sickle. Plus everybody who has pitched in from Jharkhand, from Shivaji Kumarji, from Bihar, from Gujarat, from Chhattisgarh, from Madhya Pradesh, Munshiji. So it has been a great, I think, event. Thanks, Dr. Kharia, also for coming forward with the idea of transplant, how best we can do that. So I personally feel it has been a great opportunity. The only two issues which are coming up everywhere is a decentralization and how we can control the situation in the district. So as all of you know, our cancer program is doing extremely well beyond 150 districts. And there are few principles of healthcare systems which we have changed and proven that they work. The first and foremost system is decentralization does work. Second most important thing is you need non-experts to manage the system. You do not need experts because experts are busy in their expertise. So we will need non-experts to manage the system. So a medical officer should be taking care of all the program in the district and should be reporting to a bigger officer in the state. So I think this fundamental health process thing, what comes to my mind, could be thought over. It's a thinking process. There is nothing 100% sacrosanct. So I still thank everybody that the problems which have come up, I'm sure there are a lot of solutions available. And in our one of the meetings, we should try to bring in maybe other solutions. But I again thank everybody for coming forward in these large numbers to show that the cause of hemoglobinopathies, which NHM is taking up for last 5 years, really matters. And I should thank NHM that the cause taken care by NHM is actually reaching public. So public is aware of NHM and people are now really coming forward to really fight hemoglobinopathies. Thank you very much. Thank you everybody again.
Thank you so much. Thank you so
This
much.
episode will be available on YouTube on our channel of Manage Health Foundation. Those who have missed part of it can see it. You can share with others who would like to see these sessions by each faculty. Thank you very much, Vinita madam.
Thank you.
Thank you, Dr. Rajesh, and thank you, Dr. Pindarkar. It was great listening to everybody. Thank you. Thank you so much.